Good morning. I'm unmuted.
Okay, good morning, everyone. Welcome to Wednesday morning rounds. Just a couple updates. Please remember to submit your MOC credits to the Royal College. The deadline is January the 31st, and everyone should be able to do that on their main port login page with the Royal College. So we'll get going this morning. This morning, it's my pleasure to introduce one of our senior cardiology residents, Graeme Prosperi-Porta. He's going to be talking today on the left atrial appendage. So thank you for joining us this morning, and we look forward to your presentation.
Thanks. All right. So I'm just going to get into it. So I've kind of stumbled into the left atrial appendage and really kind of stroke assessment in some research during my time here, even though I'm going into interventional cardiology next year. So I'll get started. There we go. So every good cardiology presentation starts with some embryology. So the heart really starts to form between week 3 and week 7. It starts with 2 endocardial tubes that then fuse and form kind of the primitive heart, which is composed of the truncus arteriosus, the primitive ventricles, and the primitive atrium. It then undergoes this counterclockwise rotation to bring the primitive atrium up to its final resting place. During that time, the primitive atrium develops these pectinate muscle ridges, and the pulmonary vein buds begin to grow actually towards the left atrium. It then fuses in this process called intussusception. The left atrium is formed as it spreads the smooth muscle that we see in the final form of the left atrium and sort of pushes the left atrial appendage out of the way. We see it finally there. So why is that important? Well, the anatomy of the left atrial appendage after it's fully formed takes the shape of 4 main anatomical configurations: the cauliflower, which is the least common, the windsock, the cactus, and the chicken wing. And these are all what it looks like on imaging. And this is important because the different morphologies of the left atrial appendage have been implicated to have different stroke risks. So when you look at it, there's increasing risk of stroke going from chicken wing, which is the lowest, to windsock, cactus, and the highest, which is cauliflower. And this has even been shown in patients with a CHAD score of 0 to 1, so low risk of stroke. There's a 10 times increase in stroke in patients with non-chicken wing morphology compared to those with chicken wing. And we have to ask ourselves, why is the stroke risk higher depending on the morphology? And so there's been studies that have looked at patients who have left atrial thrombus and characterizing it by the number of lobes of the left atrial appendage. And they've shown that patients with greater number of lobes, 3 or 4 lobes, have a higher risk of left atrial appendage thrombus. And trying to understand why that is, as you increase the number of lobes, we see an increase in spontaneous echo contrast, so sort of stagnant, slow blood flow. As well as the number of lobes increase, we get a decreasing emptying velocity. So again, stagnant blood flow. The study on the right, I think, is interesting. They took patients who were waiting for pulmonary vein isolation without a history of clinical stroke, and they did MRIs on their brains. And they basically counted the number of little dots from these embolic, subclinical, silent embolic events, and they put them into quartiles. And what they found is the black is the highest quartile. Over 44 subclinical ischemic events on the MRI, and it was much higher in patients with windsock and cauliflower. So there's something to do with the anatomy and stroke risk. So sort of to summarize that, the left atrial appendage is an embryologic remnant with 4 predominant morphologies: chicken wing, cactus, windsock, and cauliflower. And the anatomy of the left atrial appendage seems to be related to stroke, although we don't classically factor this in. I've always wondered, is the left atrial appendage just a passive container? Well, it's actually not. You can see here on the right, the left atrial appendage is highly contractile, typically has an ejection fraction of about 50% and a normal emptying velocity of 40 to 50 centimeters per second. They've found, back in the 90s, that patients with left atrial appendage thrombus were more likely to have a larger left atrial appendage, a lower emptying velocity, and a lower ejection fraction. And you can see this is a TE pulse wave Doppler where they're actually measuring the left atrial appendage emptying velocity with that late diastolic emptying. So is this just atrial fibrillation? The answer is no, interestingly. It can really be with any cardiomyopathy. So this was an old study in the 90s. Where they took patients who were admitted with a dilated cardiomyopathy, both those whose main presentation was an embolic event and those without an embolic event. And they found that 83% of patients who had an embolic event with dilated cardiomyopathy and no atrial fibrillation had a left atrial appendage thrombus. And about 12% of patients with no embolic event also had a left atrial appendage thrombus. So it's not unique to atrial fibrillation. It's really a problem of atrial cardiomyopathy. And all of this predisposes us to develop a left atrial appendage thrombus because of Virchow's triad. So we get endocardial damage because of this atrial remodeling process and progressive fibrosis. These patients have an elevated inflammatory state, which causes them to be hypercoagulable, and they get stasis because of poor left atrial appendage function, which results in the development of thrombi. So to summarize that, the left atrial appendage is not normally a passive pouch, and cardiomyopathies, mostly atrial fibrillation and atrial flutter, but any cardiomyopathy increases your risk of left atrial appendage thrombus. So the question is, how long does it take for a left atrial appendage thrombus to form? So back in the 90s, they thought 72 hours was the cutoff. And so the first study that really looked at this, they took patients with atrial fibrillation and looked at them in the acute less than 72 hours or chronic, and they did TEEs on them. And patients who were presenting with atrial fibrillation with symptom or clear onset less than 72 hours had a 14% risk of a left atrial appendage thrombus. And this was obviously higher in patients who were coming in with an embolic event compared to those without. The next question is, where do these form? Where do these thrombi form? And this comes from, again, from the 90s, where they did a meta-analysis without calling it a meta-analysis. And they took all studies that they could find in non-valvular and rheumatic atrial fibrillation, and they looked at where they came from. Some were TE, some were autopsy, but they found that the left atrial thrombus is at least 90% of the time the culprit for where thrombus forms. Versus in rheumatic atrial fibrillation, it's only about 57% of the time in the left atrial appendage. So to summarize that, without anticoagulation, left atrial appendage thrombus is common, and in non-rheumatic atrial fibrillation, it's in the left atrial appendage over 90% of the time. So I've talked about the left atrial appendage morphology and its relation to risk, the left atrial appendage function and its relation to stroke risk, but I haven't talked about any of the clinical risk scores. And there are a lot of them. There's 19 different clinical risk scores that have been developed. And you can see here there's a lot of commonalities between them: congestive heart failure, hypertension, age, diabetes. But there's some oddballs that we don't always look at: high sensitivity troponin elevation, BNP, smoking, LVH. And there was a nice meta-analysis recently that tried to sort of summarize these. And what they looked at was so all of the different stroke risk prediction tools, all the way from 94 to 2021. And they looked at how many times these have been iterated and validated. And for the CHADS VASC score, it's been validated 147 times, and the CHADS score 75 times, which is far greater than any of the other risk scores. And so that's one of the reasons that we've been left with using these in clinical work. But how good really are they? So they also looked at the C statistic for each of these. And at the top, you can see 0.5 to 0.7 is okay, 0.7 to 0.8 is good, and above 0.8 is excellent. And none of these really have excellent clinical predictive capacity. You know, the CHADS is pretty good. The CHADS VASC is pretty good, but they're not excellent by any means. So how do they work in the real world? So in patient, what we've discovered is that if you anticoagulate them, the stroke risk goes down. But by how much? This is always a question that I ask myself. And so really the initial studies used warfarin, and they showed that if you have a CHADS of 0 to 1, your stroke risk on warfarin goes down to 0.89%. If you have a CHADS of 2, it goes down to 1.4%. And if you're 3 to 6, it goes down to 2.5%. It's never completely gone. There's always still a risk. And you're wondering, why am I talking about warfarin? Well, it was the first. It's clearly been outdone by all of the direct oral anticoagulants in a number of landmark studies that I won't get into. But they all have lower risk of embolic events and at the same time, a lower risk of bleeding. There's one caveat recently is in patients who are frail and elderly and stabilized on warfarin. And so there's a recent study published at ESC that basically took patients who are stable on warfarin, elderly and frail by this Groningen frailty index, and they looked at a primary endpoint of bleeding, major bleeding, and secondary endpoints of thromboembolic events. And so you can see that there's a much higher risk of bleeding when you switch these patients to oral anticoagulants, which I know I've done numerous times. And so that's a really interesting study. I think the one caveat to DOACs being better. So to summarize that, the CHAD score is good, not great, but there's probably nothing better. And anticoagulation clearly decreases the risk of stroke. That's proportional to the CHAD score. I'm going to switch gears a little bit here and talk about cardioversion. This is one of the things that I'm interested in from a research perspective. So the first real report of cardioversion was back in 63 in the New England Journal of Medicine, where they took 50 patients, mostly with rheumatic mitral stenosis, and did the first 65 synchronized cardioversions on them. Most were on the top-notch antiarrhythmic at that time, quinidine. And what they did was they sequentially increased synchronized cardioversion from 100 to 400 joules, each by 100 at a time if it wasn't successful. And they actually were pretty good. They had a success rate of 89% and only one splenic embolism. So how are we doing now? Have we really improved our ability to electrically cardiovert people? So now cardioversion is probably about 92% effective, so not much different than 1963. Our stroke risk is anywhere from 0.5 to 0.8% in all comers, but it's relatively safe. There's a meta-analysis from a number of Canadian cardioversion studies that really show the risks of cardioversion are mostly related to the sedation. So patients have some issues with hypotension, respiratory events where they need to have some airway maneuvers or become hypoxic. Skin burns are very rare. Patients will have pain, but most of the complications are not stroke. So how do we decide? This is sort of the holy Bible that we use to decide who we can cardiovert immediately and who we have to wait. And so in patients with non-valvular atrial fibrillation, less than 12 hours with no recent stroke, you can do immediate cardioversion. In hemodynamically unstable patients as well. And in those with a duration of 12 to 48 hours with a low CHADs of 0 to 1, they can be cardioverted immediately. Everybody else needs some sort of imaging first. And so what's the data behind this? The best study that I found was the Finnish cardioversion study, and they basically tracked patients who were cardioverted in the emergency department. About 2,500 patients, all under 48 hours, and had an overall rate of 0.75 embolic events. What you can see is that the thromboembolic events are never zero. These patients were not anticoagulated either before or after. And even if you're presenting under 12 hours, you have a 0.3% risk of developing a stroke. And that's even in patients who are a very low CHADS VASC, who we normally wouldn't anticoagulate. So what happens when you then anticoagulate these patients after? Well, the stroke risk, if you look in a population of about 1,700 patients, mostly from Ottawa and, mostly from Ontario and Canada, the stroke rate is about 0.1%. So clearly anticoagulation in these patients after their cardioversion is beneficial. So we have to ask ourselves, why do people have strokes after they've been cardioverted? Because there's a clear association. I think there's two reasons. One is that even if you do TEEs in patients under 48 hours, those who are not anticoagulated, this study found that there was a 4% risk of them having a left atrial appendage thrombus coming through the door. The other reason is always this atrial stunning. And so the first real report of it was in 1994, and they implicated a couple of reasons after you cardiovert somebody that their left atrium and left atrial appendage does not contract. So they implicate maybe it's a tachy-mediated cardiomyopathy, maybe their L-type calcium receptors downregulate after being flogged with intracellular calcium from tachycardia. Maybe the atria goes into hibernation. Maybe the myocytes de-differentiate. Maybe there's more atrial fibrosis that takes time. Overall, the problem is that there's increased risk of stroke after the cardioversion, even in low risk patients. So we have to trust whatever the mechanism is, there's a higher risk of stroke. And I've been asked the question before, well, is it the cardioversion, is it the electrical cardioversion that does it? There's even data in patients getting pharmacologic cardioversion that they still have a higher risk of stroke after they've been cardioverted. And so it's not the act of the actual electricity going through the heart. It's something on a more cellular mechanism. So what about patients presenting over 48 hours? We can't immediately cardiovert these patients. We either have to anticoagulate them for 3 weeks, or we need to look at their left atrial appendage. And the guidelines right now say with a T. So where does that come from? So there was a study in 1995 that took 231 patients before going to the operating room, and they did TE on them, and they looked at whether or not they had a left atrial appendage thrombus directly by visualization in the operating room. And using TE, they found a sensitivity excellent of 100% and a specificity of 99%. And overall, the prevalence was about 5%. It's not a big study, but this is what has guided us on TE being the gold standard. So does it work clinically? So they did a study in 2001 looking at TE guided cardioversion in the emergency department. About 1,200 patients, and they were randomized to TE guided cardioversion or conventional therapy, which at that time was warfarin for at least 3 weeks, and then cardioversion. They found no difference in their primary endpoint of embolic events, 0.8% in the TE group and 0.5% in the conventional group. But I found a few interesting things is that by 8 weeks, the rates of sinus rhythm were both about 50%. And the symptom score at that time was the DASI score, also no different. So it's really made me question how good is cardioversion. To summarize that, the risk of left atrial appendage thrombus and related embolic events is never zero. Anticoagulation prevents these embolic events. So I mentioned before that the guidelines recommend TEE as the gold standard, and this is their actual statement. Although other imaging modalities, such as CT and cardiac MRI, might have comparable sensitivities and specificities to those of TEE, only TEE has been subjected to a randomized trial. And accordingly, TEE remains the gold standard for this purpose. Other procedures may be used when TEE is contraindicated. So I want to look at CT. So when we look at the sensitivity and specificity of CT, it's now compared to TE. This is from a meta-analysis looking at all different types of CT imaging for left atrial appendage. And the one that has become the best and the kind of standard of care is this delayed imaging, where they inject a bolus of contrast and you image the heart about 90 seconds later. This study, there were 2,200 patients, and they found a sensitivity of 99% and a specificity of 100% with a prevalence of 5.8% using CT compared to TE. And you can see this left atrial appendage thrombus here. So I got involved, sort of adopted the LA Clot trial that we were doing at the Heart Institute, and I'm happy to say that we were able to get it accepted to JACC Imaging recently. So I'm going to go over the final results from this. So in patients over the age of 18 who were admitted to the Heart Institute for atrial fibrillation or atrial flutter who needed left atrial appendage imaging before cardioversion, we randomized them 1-to-1 to TE versus CT. And the primary outcome to help with sample size was the time to imaging or spontaneous cardioversion. So not a hard clinical endpoint, but something that we thought would be a surrogate. So you can see here the two imaging modalities side by side. There's clearly limited movement of the left atrium. You can see some spontaneous echo contrast and a thrombus at the tip of the left atrial appendage. And that same image that I showed before of the left atrial appendage thrombus on CT. So these were both patients that were in the LA Clot trial. We randomized 52 patients in the CT arm and 50 in the TE arm. And I have a few kind of notable things that I think are important. So you can see the arrows, the average ejection fraction in these patients was 35 to 40%. So really a heart failure population. They all had poor renal function with creatinine of 120 to 150, and many had elevated BNP. So it just tells you the type of patient that's being admitted to the Heart Institute for cardioversion. We found 6 patients total had a left atrial appendage thrombus. 11 patients spontaneously cardioverted while they were here at the Heart Institute. 2 went for direct ablation, and 6 were unable, in the TE arm, were unable to complete imaging. 2 of these were due to delays in getting the TE, and they crossed over to the CT arm. 2 were because they were unable to get the TE probe into the patient, and the other 2 patients then refused TE. So the primary endpoint here, imaging or spontaneous cardioversion, was about 7 hours in the CT group and 30 hours in the TE group. And what I think is the most interesting thing from this study is that the total length of hospital stay was unchanged. And I think that that really has to do with the population that we had, which was a heart failure population, rather than just a pure atrial fibrillation population. These patients went on to get, wait for their angiograms, get put on guideline-directed medical therapy, and had many other things limiting their hospitalization, not just the cardioversion. Fortunately, we had 0 episodes of stroke or embolism. And in terms of acute kidney injury related to the contrast from CT, there was no difference. One thing that we did find that was interesting was that at discharge, patients who underwent CT had a lower emotional distress score, so better quality of life, and their health score, their subjective how healthy am I, was increased in the CT group. It's not definitive because it was only a few of these scores, but it makes you wonder if people prefer CT for some reason. So to summarize, patients admitted to the Heart Institute for atrial fibrillation or flutter, I can see a few people laughing, are often here really with heart failure as their presentation, and the atrial fibrillation or flutter is kind of a bystander. And I think the results from LA Clot and that meta-analysis showing the sensitivity and specificity, I think CT is a very reasonable alternative in patients to rule out left atrial appendage thrombus before cardioversion. And you have to sort of weigh what are the extra benefits from TEE versus CT that you get. So in a patient who also has valve disease, you may want to do that TE because you'll get better information. So you'd really have to weigh that. But LA Clot is really just the tip of the iceberg in terms of patients with atrial fibrillation. We see very few of the patients that come through the emergency department. And so that's really where I think some challenges are and some improvements can be made in the next steps. So to put this into perspective, there's the Blitz AF study, which was an observational study out of mostly Italy. And they showed that 1% of all emergency department visits are related to atrial fibrillation, but it accounts for 1.7% of hospital admissions. And there, 27% of patients are admitted to the hospital. That's not quite the same numbers as in Canada, as I'll show you. But what I found interesting is that in the emergency department, only about 1.5% of patients undergo a TE-guided cardioversion, whereas once they're admitted to the hospital, 16% get a TE and 38% get cardioverted. When we look closer to home, this is data from Canada. Patients who get electrically cardioverted in the emergency department have an admission rate of about 10%, compared to those who are treated with rate control are admitted 30% of the time. And these are patients with just pure atrial fibrillation. They don't have any other reason for admission. They don't have infection. They're supposed to not have heart failure. And when you look as well, their 30-day readmission rate seems to be lower at 16% compared to 20%. And so there's potentially some room to help prevent hospital admissions and hospital utilization with cardioversion. So there's been a lot of work done in Ottawa with Ian Steele, and also Dr. Burney has been a part of a lot of these studies. And one of theirs was the RAF3 study, where they implemented essentially a protocol, a guideline in the emergency department of who you can cardiovert and who you can't. And when they looked at this, what they found is that they increased cardioversion from 67% to 85%. They reduced inpatient consultations, yippee, from about 50% to 40%, with really no major adverse events, 0 strokes, and only minor complications, the same ones, airway, hypoxia, hypotension, mostly related to sedation. One thing that I found interesting is that they really didn't make a big movement on admissions to hospital. It only went from 8.6% to 7.7%, despite the increase in cardioversion by almost 20%. So atrial fibrillation is a major burden on hospital resources, and cardioversion might be associated with less admissions, and cardioversion is not unsafe. So why not just cardiovert everybody that comes through the emergency department? The study that really brings some question into my mind was one that was published in 2019. What they did is they took everybody with recent onset atrial fibrillation, so less than 48 hours, and randomized them to immediate cardioversion versus delayed cardioversion. The delayed cardioversion, they went home, they came back in 48 hours. And what they found, their primary endpoint of sinus rhythm at 4 weeks was no different. The thing that's more interesting is that in the delayed cardioversion group, 69% of them spontaneously cardioverted by 48 hours. So it really makes me question, do we need to cardiovert people at all? When we look at, recurrence of atrial fibrillation during that time, it made no difference. And when they did a meta-analysis of all of this, you can see that the trend of time, so up to 48 hours, and then there's 2 studies, one at 30 days, which shows the rate of spontaneous cardioversion is about 80%. We know from the East AFNet4 that early rhythm control with medications, antiarrhythmics, or with catheter ablation is superior to standard medical therapy, really rate control. But the question is cardioversion equivalent to early rate control? And I think that's what we don't know. There's an interesting registry, the Orbit AF, that looked at this. They looked at patients who came in through the emergency department and got electrically cardioverted. And they looked at their symptoms, their hospitalizations, and their atrial fibrillation progression, meaning paroxysmal, persistent, permanent. And what they found is that patients who were cardioverted had really no change in their European Heart Rhythm Association symptom score. They found that they actually had increased hospitalizations and healthcare utilization. And for some reason, they also had an increased progression of their atrial fibrillation. They postulate this is probably because the patients that are being cardioverted are more symptomatic. They have a different disease process than those who are coming in and not being cardioverted. But it certainly makes you wonder, whether cardioversion helps. So cardioversion is likely to happen spontaneously. Cardioversion might not help long-term out symptoms, and cardioversion might not prevent future hospitalizations. So in my mind, the answer is whether to cardiovert or not. I'm going to leave it as a bit of a cliffhanger. We're in the process of finalizing another trial in the LA Clot series that we're doing multi-center across Ontario that we're hoping to answer this question. I'm going to switch gears a little bit and look at other ways. So if anticoagulation is not well tolerated, what are our other options? So the problem with anticoagulation is people don't like taking pills. People bleed, and doctors don't always prescribe them at the right doses to be effective. So about 12% of patients are prescribed DOACs at an incorrect or underdosing. And when patients are prescribed DOACs at a lower dose than has been proven in the clinical trials, they have an increase in all-cause mortality and an increase in risk of stroke and systemic embolization. So we really have to ask ourselves, how else can we try to prevent stroke in these patients? So the first thing I'm going to talk about is left atrial appendage excision. And just briefly, there's a study, the Laos 3 study, which happened in Ontario out of Hamilton. They took patients greater than 18 years of age who had atrial fibrillation and CHA2DS2-VASc 2 or more undergoing cardiac surgery of any kind, CABG, valve. And what they did is that they excised their left atrial appendage. They randomized about 4,800 patients, and they looked at the primary outcome of stroke or embolism. And importantly, there was no difference in chest tube output. There was only a 4 to 5 minute difference in surgical time. And there was no difference in return to the operating room for bleeding at 48 hours. What they found is that the risk of stroke or systemic embolism at 3 years was significantly reduced in the patients who had their left atrial appendage removed. But you can see here that, only there's still 20 to 25% of patients who were not taking their anticoagulation at 3 years. And in this study, it was not a way to get off of anticoagulation, but to provide additive risk. So when patients go for left atrial appendage excision, they still need anticoagulation. There's an interesting study that's going to be kind of next in this series, the LAX-2 trial, where they're going to be randomizing patients at risk of atrial fibrillation to removing their appendage during cardiac surgery. And so we'll be waiting for the results from that study in a number of years. So to summarize, left atrial appendage excision reduces stroke and systemic embolism and should be considered in patients with atrial fibrillation undergoing surgery. But it does not negate the need for anticoagulation. So we're all thinking of those patients who are recurrently bleeding, can't take their pills, and so we need a way to get them off of their drugs. So left atrial appendage occlusion is what has been studied in this respect. So there's two devices, the Watchman and the Amplatzer, and you can see that they put this plug right in the left atrial appendage with the hopes of endothelialization occurring over and obliterating the left atrial appendage cavity. There's two main studies that were first developed, the PROTECT-AF and the PREVAIL trial. They were run at roughly the same time. They took patients with a CHADS greater than or equal to 1 who were eligible for warfarin, and they put in a Watchman, the original Watchman. The PREVAIL study tried to enroll a slightly higher risk cohort with females 75 or older, patients with moderate LV dysfunction, patients 65 to 74 with diabetes or coronary disease, or those over the age of 65 with heart failure. And what they did is that they implanted the Watchman device. At 45 days, they did a TEE and they looked for leak. If there was no left atrial appendage leak, then the patients were switched to dual antiplatelet with Plavix and aspirin. And at 6 months, they were switched to just aspirin monotherapy. If there was a leak, then they were continued on their warfarin until there was no further leak, and eventually put on aspirin monotherapy if there was no leak. So when they finally reported the results, they did it as a combined endpoint of both trials. And you can see that for their stroke and systemic embolism as their primary outcome, there was really no difference. But there was a significant reduction in secondary endpoints, hemorrhagic stroke, and decrease in major non-procedural related bleeding. And you can see a lot of that comes from the PROTECT study rather than the PREVAIL study, which was a higher risk group. You're all thinking again, well, we don't use warfarin anymore, so is this relevant? They had then done the PROG-17 trial, where they took patients with a history of bleeding requiring intervention or hospitalization, those with an embolic event while on anticoagulation, or those with a moderate to high risk profile, so CHADS of 3 or more, has blood 2 or more. And they randomized them to left atrial appendage occlusion. And afterwards, they put them on aspirin and Plavix for 3 months, or if they are high risk of bleeding, that strategy could be adjusted to 6 weeks, or a DOAC for 6 weeks, and then DAPT for 6 weeks. And they checked if there was a leak on the device, and if there was not, then they put them on aspirin monotherapy. When they looked at the outcome, their primary outcome, which was a composite kind of net outcome of stroke, TIA, embolism, cardiovascular death, bleeding, or other complications, they found that left atrial appendage closure was non-inferior. They didn't quite meet statistical significance, but there was a trend towards decreased non-procedural bleeding in these patients. So it's possible to occlude the left atrial appendage and get somebody off of their anticoagulation, but it comes at a small risk of procedural complications. So the very low risk of death, stroke, systemic embolism, so about a 1% chance of pericardial effusion and tamponade. Device embolization is low. And then the more common complications are peri-device leak, which if it's greater than 5 can be significant, or device-related thrombus at 3 to 5%. One of the really interesting studies that's going to be starting is the LAOS-4 trial that's going to be looking at patients with atrial fibrillation who are able to take anticoagulation, who are higher risk, and they're going to put in a left atrial appendage occlusion device in addition to usual care and look if it's additive in preventing stroke. And so that's something I'm excited to see in the next couple of years. I mentioned that leak is a problem in these patients. And so you can see from the left, these are a lot of the studies and registries. Peri-device leak is relatively common in these patients, kind of 10 to 30%. Usually it's minor, but the presence of a peri-device leak is related to an increased risk of stroke or systemic embolism. And the increased size, the larger the leak, the greater the risk of stroke. The ways that it can leak is it can leak around the device. It can leak into an uncovered lobe of the left atrial appendage. And it can leak through the fabric of the device. And this happens both with Watchman devices as well as the Amplatzer devices. And so, you know, the structural interventionalist that put it in will really guide a lot of this. But to give you a little bit of background, so if the leak is small, so less than 3 millimeters, typically you will watch and wait. You may repeat imaging in the future. If the leak is significant, you will consider treating it. So greater than 5 millimeters on TE. You can, if their bleeding risk is prohibitive, then there are a number of ways that you can close it. If their bleeding risk is not prohibitive, then some people would continue with their oral anticoagulation. And a number of ways that you can close it. So one is you can coil it, so you can completely obstruct the left atrial appendage with coils and cause it to thrombose off. You can put in another device if there's a large lobe that's still uncovered. You can plug it or occlude it, and there's also ways to radio frequency ablation. I'm not sure many of the interventionalists have that tool in their toolbox. So to summarize, left atrial appendage occlusion can be considered in patients who are high risk for embolic events and not suitable for a long-term anticoagulation. But we have to appreciate that left atrial appendage occlusion carries a small added peri-procedural risk, and incomplete closure results in incomplete stroke prevention. Thank you.
Thank you, Graeme. That was a very good overview. If you have any questions, we'll.
Dr. Chan?
Excellent talk.
I think they're going to bring you the mic.
Okay. Excellent talk. My question really is that from your review, what is the rate of complete occlusion of the left atrial appendage after the device is placed? I would add to that because from my experience, I have not seen a single one where the left atrial appendage is complete thrombosed. I have not seen one. So I would be very interested in knowing what the literature number is.
Yeah, I didn't come across. Go back. So they mentioned. So in this was from a recent review paper from Al-Khoury, and they don't actually. I didn't read a rate of total thrombosis of the left atrial appendage. I would be surprised if that really actually happens. I didn't come across anything like that. The rates of peri-device leak, I think, are coming lower and lower and lower now that operators are better. The technology is getting better with the Watchman Flex has really been designed, the new Watchman device designed to prevent any leaks from forming. It's more flexible and able to conform to the irregular orifice.
But we don't know. If we don't know whether this happened or not, that is whether left atrial appendage thrombosed or not, then your algorithm that is not applicable. I have not seen a single case actually. That work. I think it may be related to the design of the device, the fabric, where the blood still goes through that. I don't know anyone have seen a left atrial appendage complete thrombosis after device closure. No, I just haven't seen one, right?
Could you comment on the protocol here, post occluder? What's the antiplatelet strategy in the early post-procedure phase and then long-term?
Yeah, so what I've seen is really dual antiplatelet therapy, and timeline kind of depends on the patient, but yeah, typically kind of 6 weeks. I don't know if that's different than what you do.
Thanks, Graeme. Great talk, great overview. Couple of things. Yeah, so I would say the vast majority of patients that we do, if not exclusively, are patients who can't take oral anticoagulants. They, they've bled, or they're on, or they have anemia and stuff like that. So, they're not on it. So couple of things. We don't, we try to keep them on DAP for 6 weeks at most. And I have lots of patients that can't take it for 6 weeks. Some can't even tolerate aspirin. So some of the cerebral amyloid patients can't. So very short periods of time. The other thing is, I'm just pragmatic about it as well. If they can't take oral anticoagulants, then why do a TE on them to see the leak, right? Because you've done the best you can. They're on the DAP. They're going to stay on aspirin, if not anything. So that's about it. Speaking to Dr. Chan's question, I don't think that any studies have seen the thrombus, but, I would say in the study patients that we've done, that we have less than a 3 millimeter leak in well over 90% of patients with either device. And then the final thing I just want to say is I want to plug, we will do LAUS 4. We're just going through ethics, which, as you know, here takes 3.5 years to get through. But besides that, we're also still randomizing for Catalyst. Catalyst is a randomized trial for patients who can take oral anticoagulant, because that's the big question, right? Because it was compared to warfarin, and warfarin was, but nobody uses warfarin anymore. So everybody's talked about, there's been registries and observational studies suggesting that they're superior to the oral anticoagulant, but these are registries, so can't make conclusions. So Catalyst actually is randomizing patients who can take any one of the 4 direct oral anticoagulants and comparing it to Amulet, which is, it's sponsored by Abbott. It's the dual closure device, and there's data suggesting that it might be better than the Watchman because it's got 2 layers of occlusion. I'd encourage all of you to send me patients, because it's surprising to me. I was just saying this at rounds this morning, that when I talk to patients, they say, "Hey, doc, I don't really care. I take a pill twice a day or once a day. Why would I want to have a procedure?" And so I don't know if other of you have other patients that want to get off their oral anticoagulations, but if you have patients, please send them along. I see some centers in the States just recruiting like crazy. I'm not sure how they're selling it there, but here we're not recruiting as vigorously as I thought. I thought people would want to be off their oral anticoagulants. Maybe just the way I sell it, but if you have patients, send them along.
Thank you. Great talk, Graeme, and great review of the background and the history leading up to this. One point and then one question. I guess Dr. Labin has answered my question. Can we send you an email if we have a patient in mind for the Catalyst trial? Bailey Morgan. Okay, thank you. And then just excellent. And then just a point about the LAUS 3, the surgical exclusion. The method of surgical exclusion was various in the trial and seems to matter in real life. I'll say that on the TEE side, in the last month, I've seen 3 cases which have had surgical exclusion, which then either the stitch slipped and the appendage is completely open, or the sutures maybe slipped partially, and then there's a channel and actually thrombus within the existing appendage. So it's also not a guarantee and something to think about. Just a comment there.
Yeah. In that trial, they allowed the surgeons to choose how they wanted to close it. Some closed it with sutures, some closed it with sort of a clip. Others actually cut the whole left atrial appendage off and oversewed it. I don't know what the standard practice is here, or if it's also quite variable. It sounds like some are just putting some stitches in it. But yeah.
Thanks, Graeme. You mentioned first that the C value for the CHAD score was around a little bit below 0.7, and you mentioned the role of the anatomy of the LLA.
Yeah.
Should we integrate that into a score?
Yeah, it's something that after doing this, I want to look at, especially in patients who are, you know, a CHAD 0 to 1, where you might not anticoagulate. So it's something that after doing this, I'm going to talk to Dr. Chow and see how we can collect that data from CTs that they have, because I think that would be really interesting.
And for echo.
Yeah.
Graeme, can you see on your Teams meeting? I think someone has their hand up with a question. I can just see the hand, or whoever you are, if you can unmute yourself and go ahead and ask your question.
Dr. Golian first.
Oh,
Thank
okay.
you.
Thanks, Graeme. Can you hear me?
Yep.
Perfect. So a couple of comments and one question for you. Comment one, I think, you know, the rate of cardioversion you showed was 92% in the emergency department, but just wanted to put a little stitch for Dr. Ramirez's protocol with Dr. Burney. That one is like 99% success rate at immediate cardioversion. So that's just a protocol that we have at the Heart Institute. That was, I think, published in 2019 or 2020. The second comment, we just had a journal club on this with the surgeons, and they do actually mostly do excision here. They don't do the stitch closure. So that's a good thing. And then the third comment, considering that, you know, if you look at CT scans of these patients, majority of the left atrial appendage closures will have a leak, you know, over 50% in the, if you use a CT scan, not looking at it with an echo. Now, what that corresponds to in terms of, you know, risk of stroke, I think is a little bit less clear. But the number of patients that have, you know, full CT scans afterwards is also less compared to the data that we have with patients with TEE. And also considering that most patients that have a bleed on anticoagulation can be given a retrial of anticoagulation, and they do fine, you know, even if with intracerebral hemorrhage. What patients would you right now send? You know, I think Dr. Lavin has mentioned, you know, patient with amyloid that can't be on anything. Other than that, is there any patient population that after reading all these things, you would routinely send outside of a study for left atrial appendage closure without retrying them on an anticoagulation?
Yeah, I think that's it's a good question. I know that, you know, the rates of left atrial appendage occlusion in the US far exceed rates in Canada, and there was a curve that it's just continuing to increase. So I think more and more patients are going that route. They don't want to take anticoagulation, and you know, I'm still very early in my practice, but I would consider referring anybody who's had a major kind of life-threatening bleed or recurrent bleeding for a left atrial appendage closure. I think right now, until we have data from LAOS-4 or Catalyst, we don't know if there's a benefit for patients to get it without sort of a contraindication to anticoagulation.
I agree with you. If the patient is undergoing CABG under cardiopulmonary bypass, you can cut and sew.
Yeah.
But with the mid cabs or the ones that they do not go on pump is where they have to use the endo suture, because they can't cut and sew when they're not on pump.
Yeah, there are some.
So our surgeons mainly do that when they are on pump. But if, for example, Mark Ruel does a lot without, and you can see surgical notes will be an endo suture for that reason.
Yeah, there's some of these devices that they can go into the epicardium and actually sort of lasso the left atrial appendage and close it. Those are out there. I don't think they're as commonly used, but probably more if we're doing minimally invasive stuff. Yeah. Dr. Lavin is saying they're costly.
Dr. Beanlands, did you have a question?
Yeah, thanks, Graeme. Fantastic rounds. I want to go back to the beginning of your talk where you talked about a bit about atrial stunning and so on, which always intrigues me. If there's evidence that the duration of atrial fibrillation relates to this so-called atrial stunning that occurs. You may have said this, but in the patients who spontaneously convert, are they at the same risk of embolization? And then what I've seen sometimes happen is that the patients get started on amiodarone without cardioversion with a goal for rate control, but of course amiodarone can convert the patient. And whether there's any data on that, because my concern always is that these patients may have clot, we haven't ruled it out, and amiodarone could convert them.
Yeah, so I think that's a very good question. So patients who are out, so I don't understand this part. Patients who are out in the community with paroxysmal atrial fibrillation, CHAD0, and they're converting all the time. So why don't they have atrial stunning that increases their stroke risk? I don't know the answer to that. I searched for that and I couldn't find anything. Your other question about the time that they've been in atrial fibrillation in relation to the stunning, absolutely. So the longer a patient has been in atrial fibrillation, the worse their stunning and the longer it takes to get better. And these are very old studies where they sort of did serial echoes, serial TEEs on these patients. Typically, the atrial stunning will get better anywhere from 72 hours. Sometimes it takes a month for the atria to get better. But the longer they've been in it, the longer and worse that their stunning is. And your other question about amiodarone. So, I always look at it from the perspective, we use amiodarone sometimes for rate control, especially in the CCU when patients are sick, we can't beta block them, they're fast. I always look at amiodarone like, if I'm looking back, my patient had a stroke, I started them on amiodarone. That feels like it would be my fault. And so I personally try to avoid antiarrhythmics in patients without anticoagulation at all costs, unless they've either had a TEE or they've been on anticoagulation for 3 weeks. That's kind of me. And there's other strategies. I think digoxin surprisingly works quite well in the short term. And so that's what I would reach for often, not as a long-term medication. But yeah, I worry about amiodarone without anticoagulation.
Yeah, likewise. Thanks, Graeme. Great rounds. Really
Thanks.
good.
Dr. Nair?
Can't hear.
I think you're.
Can't hear you, Dr. Garish.
Can you hear me now? Yeah, so the current Canadian guidelines say that if somebody's been in AFib for more than 12 hours, they have a risk for stroke. Case in point is recently, Dr. Labanez and I were in CCU, patients spontaneously cardioverted and embolized everywhere. So that risk is not avoidable. But we have patients in CCU who are in cardiogenic shock who will die if you do not control. And there is a theoretical risk. So amiodarone in the first 48 hours is the most expensive beta blocker. It has clearly we know that a lot of patients will spontaneously cardiovert, even if you don't do anything. So you have to weigh the clinical scenario. Digoxin in a neuroendocrinological activated system is almost useless for rate control and potentially toxic because it's renally excreted and they can quickly go from there to the toxic levels and cause ventricular proarrhythmias. If you can do a TEE and there's a huge clot, then we can't do anything. But a lot of these patients are so sick with cardiogenic shock and their atrial rhythm. Like we have a patient with aortic stenosis with a valve area of 3 with atrial tachycardia going on. So we've used amiodarone and bitten the bullet. There's no way around it. And also to remember, patients with CHAD score of 0, their stroke risk is not 0. They do have strokes. The only thing is you can't rectify, fix it.
Dr. Beanland, it's just, it's a very interesting question. And, the other piece of information that we have that makes it even more confusing is from the Artesia trial. So the Artesia trial was looking at patients with pacemakers and their long-term risk of stroke related to SCAF. So it was the one that predated the one that's just been published. Anyway, they showed that of all their stroke events, none of them were temporally related to atrial fibrillation. So Yeah, so there didn't seem to be a relationship between spontaneous cardioversion and stroke in that population. I've always thought that there's something different about mechanical cardioversion and chemical cardioversion. You have to believe that it does something.
There is actually some preliminary work which showed that once you get mechanically cardioverted with a shock from outside, usually 360 joules, there's more atrial stunning and atrial, they looked at velocities into the appendage, which is a surrogate marker for LA function. They are reduced. I mean, if you shock somebody with 360 joules of biphasic shock, they have more stunning than if they spontaneously cardiovert. But the point is, having atrial fibrillation increases your stroke risk. The question is, at what level do we intervene with anticoagulation? If there's so we had a patient who was in cardiogenic shock with a LA appendage clot and consistent atrial flutter. We took him to the lab and did the flutter ablation, and with the understanding that it may embolize. It didn't. Patient recovered. LV normalized, went out to CC. So clinical decisions have to be made based on risk-benefit ratio after discussing with the patient and the family and the care team. So it's not like you won't get ideal clinical scenarios that come in textbooks and guidelines. So you have to do that. And these eventualities are so rare. All you can do is observational studies, right? Like in ICU, you can look at all the patients who got a neuron, and if they had any strokes, I have a randomized stroke.
Yeah.
Excellent. Oh, that was a very good conversation. Thank you very much, Graeme. That was a great presentation this morning.
Thank you. Yeah. Thank you, everyone.
For those of you attending in person, please sign